I really would like to see the results of the ocrelizumab study in progressive MS because from the mechanism of action, this drug is an anti-inflammatory drug like all the others, and therefore it has to be seen whether the impact is so profound that we can say this is not only anti-inflammatory, there's also an effect on neurodegeneration. When I was a young doctor, patients were diagnosed with MS would say, well, you have MS, we can do nothing about it, try to get the best out of your life. And then they were not followed up because then they would appear if they had some complications, but regular follow-up did not exist. Now, I mean, we try to follow up patients, we try to change therapy if it's not it's suboptimal, and so there's a big difference. And I think that it's fair to say that the prognosis for an MS patient today is much better than for 30 years ago. As long as the costs of the therapies are so high, I guess this will be in the hands of neurologists and not general practitioners. And in fact, having 10 different treatments, the treatment algorithms are becoming more and more complicated. And if you have an average general practitioner, he would have 2, maybe 3 patients with MS among his patients, so he would never get the experience to find the optimal treatment. So I guess it will still be a neurologist-treated disease. People would definitely approach their general practitioner when they feel some symptoms, and the key thing is that the practitioners should listen carefully and send the patient to a neurologist as soon as possible, because early treatment is of great importance. That's one difficult thing, that it has so many faces, this disease, and some of the onset symptoms are very easy. If you get optic neuritis, you get a significant decrease in vision in one eye. I mean, this will always get patients to an ophthalmologist, and he will say, well, this is optic neuritis, the risk of MS is large, we'll continue but if it's a mild symptom like some kind of paresthesia, a numb feeling of an arm or part of an arm, that disappears in a few weeks. People may even not go to their general practitioner, and when they came there, the symptoms are gone. So it's difficult to say this was an important thing. We need to have you examined thoroughly. There are, of course, now an issue of economy, and in some countries you don't have access to all available treatments, and in other countries there will be some regulations about which drug you can use in a different type of patients, and unfortunately this is becoming more and more common. So the idea of having a personalized medicine or tailored treatment is becoming less and less possible because of the economy. Of course, we try to convince our payers that at the end it's the best thing to get the optimal treatment for the single patient. In the long run, this will be the cheapest way of doing it. Another issue is that we try to encourage them to negotiate with pharmaceutical companies to get a better price of we have had almost free pricing in many European countries with a socialist system where the hospitals pay for everything. but now there's an issue that the budgets can't be kept, and they have to fire people to get to be able to provide the more expensive medication, and this can't go on.